So I referred to this program a little bit earlier. This is a household-based program to reduce both gender-based violence and maltreatment in reducing reproductive health. Nope, pushing the wrong button. All right, let's try this one. Here we go. So we talked a little bit earlier, and this is true in many countries, that the Indian government's current efforts to improve reproductive health involve visits to pregnant women in their households by community health workers, and this involves typically education around maternal needs around nutrition, the need for antenatal care, and of course hospital delivery. Traditionally, as again it is in most contexts, it's directed solely at the pregnant women. And as we've heard, of course, over and over again, particularly within this panel, that the women do often not control these decisions, and often communication is extremely minimal. And so the norms that need to be changed to facilitate what we're trying to do through these programs have to be done at the family level. We've talked about intimate partner violence as a major risk factor for poor reproductive health outcomes. We also, and for poor maternal health outcomes, particularly we're looking during pregnancy as well here in terms of premature delivery. Other major factors involved, not surprisingly, maternal malnutrition and low utilization of health services. Recent research that we've conducted, including Dr. Sagurthi and Dr. Raj, showed that when we were looking for these proximal mechanisms, is this intimate partner violence really a marker for something that's happening in the family that may be more proximally responsible for some of these poor outcomes? We identified a set of behaviors that we've termed gender-based household maltreatment that don't involve overt violence, and that this maltreatment is on the part of both husbands and in-laws. And actually, this nonviolent maltreatment is more so on the part of in-laws than husbands. Husbands are more likely to be responsible for the overt violence. So some of this relates directly to not allowing access to care, not allowing access to nutrition. The chance intervention, and I alluded to this earlier, really we always try to work with existing models of care. So here we're working with community health models to, instead of just working with the woman, to include the husbands and the in-laws, whereas there's a joint family. And to not just cover the bases that they normally cover, but to also address household maltreatment, which is a way of getting at harmful gender norms and dynamics without talking overtly about the violence from husbands. So here it's very brief. It works within the visits that are already taking place. I talked a little bit about the methods involved. I can talk to people further about that later. We've conducted a pilot of this thus far that looks very promising. I was talking before about the need to, when we're incorporating programs around gender-based violence into existing structures, that we need to make sure we're helping the people involved do what they want to do. And so this program was found to be highly satisfactory and to have a very low burden among community health workers. There was fear initially about their ability to really talk with the men, but after a short period of time they realized this was really helping them do what they were trying to do. So in the pilot, we did several things. We had, these are, at the outset, we had 37% intimate partner violence, 47% gender-based household maltreatment, and 58% had one of these forms of abuse. People reported these different forms that we see here in terms of nutrition and sleep deprivation. what we saw was, and this is just pre and post, and we're very anxious to get to do an RCT of this, that's certainly our next step, is that women who reported violence at baseline, 67% of them reported that after the program they were suffering less active sleep deprivation, less nutritional deprivation, and of abused women, this was very exciting to us, 42% reported less fear of their husbands, and 32% reported actual less violence. So in terms of our next step, as I said, we're anxious and we're working with different stakeholders to find the opportunity to conduct the RCT, probably in Bihar, where we're going to be able to look more at the longer-term effects of the program on broader health during pregnancy, utilization of antenatal care, hospital delivery, and hopefully neonatal and infant health. Thank you very much.